walk us through, basically a testicular mass. Let's say you're a community urologist. You have a 40-year-old who presents, feels like they felt something on their testicle, and they're coming to you.
So yeah, this is a common clinical scenario. I think first things first, when you have somebody in that kind of age range, 18 to 40 years old, coming in with a scrotal complaint, you want to, of course, get a history. Some of the things that we certainly want to ask about are history of cryptorchidism, undescended testicle, a personal family history of testicular cancer, then whether or not they've had any other types of scrotal injuries, pathologies in the past, just kind of a scrotal directed H&P. Some of the systemic things to talk about are back pain as well. You may want to ask about a history of infertility. That's some of the one of the things that can be affiliated with testicular cancer. How long have they noticed something going on? Was there any pain associated? Generally, about 90% of the time, we're talking about painless testicular masses. So that's really kind of where we want to dig into. And kind of a focused physical exam. Auscultate the chest. One of the spots that testicular cancer tends to go is the lungs, a good abdominal exam, then of course a scrotal exam. And you're trying to palpate for any type of intratesticular mass. So that's going to be kind of a ultra focused history and physical, if you will. Then the critical next steps are to get tumor markers, serum tumor markers. So that's going to be AFP, HCG, and LDH. Important to tell patients that if they're positive, it can be highly suspicious, but if they're negative, it certainly doesn't mean they don't have a testicular cancer. And then a ultrasound, a scrotal ultrasound would be another mandatory element just to kind of get the baseline workup going. If you're worried about anything infectious, a urinalysis as well.
Okay, and do you routinely ever admit these patients to get the workup, or is this all outpatient?
Yeah, it's a good question. I mean, there can be some, excuse me, socio-demographic consideration, insurance coming through the ED, things along those lines. And if I'm ever worried about that, I'll just kind of get the whole process moving. If I'm highly suspicious, even get the staging, CT scans, chest, abdomen, pelvis, and do that all inpatient admitted. With that being said, there's a couple of little nuances if you're really suspecting a testicular cancer, including getting pre-orchiectomy or certainly if they're receiving systemic therapy, sperm banking done. That's kind of a nice thing. And then also to make sure that you discuss a testicular prosthesis, which really should be discussed. That can require some logistics, including potentially having a rep bring those if they're not on formulary at your institution. So in an ideal world, you have a conversation about sperm banking, prosthesis, arrange that in a reliable patient. Most of that can be done outpatient, super advanced stage disease, and then certain socio-demographics, you just kind of got to get moving, I would say, and doing that in an inpatient setting, obviate some of the insurance, et cetera, considerations.
Sure. So fine. So, the mass is there, as you see on the ultrasound, you got the labs. When do you consider a partial orchiectomy for these patients versus, a complete orchiectomy?
Yeah, I would say in general, the standard of care for an unequivocal testicular mass outside of concomitant bilateral masses or outside the context of a solitary testicle or maybe some evidence of extreme hypofertility, the standard is going to be a radical orchiectomy. And it's going to be those considerations, solitary testicles, very small masses, equivocal masses, or bilateral cancers where you may be thinking about doing a partial orchiectomy. Important to note that testicular cancer is generally preceded by a pre-invasive condition called germ cell neoplasia in situ, which exists about 90% of the time. So even when you do a partial, many of the times you're still kind of leaving the patient with an at-risk lesion. And taking into account their preoperative fertility and androgen parameters, as well as their hopes and desires, you can do that with either careful monitoring or postoperative radiation therapy. If you radiate the testicle, the likelihood of it really producing sperm or testosterone starts becoming quite small.
Got it. Okay, understood. Okay, and so fine, let's say, the mass is excised. And then, basically, you know, you're talking to the patient about them, what are some things that you talk about in terms of prognosis and in terms of differential that you're going to talk to them about?
Yeah, sure. I mean, so first things first, I think on the front end, I always kind of go through the testes do two things. They make testosterone, they make sperm. God forbid you're hypogonadal or have some subfertility afterwards. We can sperm bank on the front end and replace testosterone just to kind of help diffuse some of the anxiety associated with that. So their pathology comes back, they've healed up. I think first things first, it's critical to have complete staging, which includes a CT scan of the abdomen and pelvis. My typical preference is just to get a CT scan of the chest as well. So I have kind of a high resolution test going into it. And critically important, and this is where the urologist is, you know, at the front lines, is making sure that you have post orchiectomy tumor markers, because A, that's a mandatory element of the staging. And B, we really want to see the nadir value of those post orchiectomy tumor markers to assign an appropriate stage. And absolutely mandatory that those markers are followed out until they normalize, plateau, or start rising, so that we don't take, for instance, a pre-orchiectomy set of markers and counsel the patient for X, Y, and Z.